give me a second. I'm setting up now to putting on YouTube so that more people can see. This takes a second. Okay. Okay. Okay, here we go. Here we go. She's 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have the pleasure of televising Asheesh Tandon for we've televised him many times. He's doing minimally invasive brain spine forum, and he has a lineup. He's going to introduce everything. And welcome, Asheesh.
Yeah, thank you, John. Thank you for organizing this third part of our craniovertebral junction. Today, we are extremely honored to have Professor Yadav and Professor Patkar sir with us. Also, I think Nitin has Nitin joined? I'm not sure. Our second moderator.
So I have joined, sir.
Okay. Hi, Nitin. Thank you for joining.
Good evening.
So I'll first introduce Nitin. He's a dynamic young neurosurgeon practicing in Mumbai right now. And he's executive of the Maharashtra and Midwest Neurological Society. And he's just organizing a conference. Patkar sir is the current president of the Midwest. So thank you, Nitin, for joining in this forum.
Thank you, sir. My pleasure.
Second in line, I would like to invite, and I'm extremely thankful to my first neurosurgical teacher, I would say, Professor Yadav sir. He introduced me to neurosurgery. Currently, we are honored and we are proud that he is the NSI president. And he has tremendous volume of work, especially in minimally invasive brain and spine. And he is a fantastic teacher who has trained almost all the young neurosurgeons in India. And he has single-handedly changed the whole culture of MIS in India. So, sir, we are extremely honored and extremely thankful for you to spare your valuable time, sir.
Thank you, Asheesh. Thank you. Grateful. Thank you.
And thank you, sir. And finally, we have Patkar sir. He is a mentor. He is a teacher. He is an innovator and extremely nice person to talk. He can, I think he's 65 now, but he can mix up with the 20s, 30s, and 65s as well. So that's in short about Professor Patkar, and I'm absolutely sure that he would create a great environment today with his deliberation. So, sir, welcome to the forum, and we are extremely thankful.
Thank you. Let me start sharing the screen. And is my screen? Can you see my screen? Hello.
Yes, sir. It has appeared.
You want to put it in presentation mode, correct?
Yes. Can you see it now? I'm in the
Yeah,
presentation.
we can see it, but there you go. Perfect.
First of all, thank you, Asheesh, for the opportunity. Thank you, John, from Miami. And let me tell you, I am not so old. I'm just 62, man. Don't call me 65 before I reach. So anyway, thank you very much. It was nice to know that I am old, but still I am young. So I will be talking about simplifying atlantoaxial fixation. In all spinal surgery, it is surgery around the atlantoaxial joint, which is, which has inherent chance of devastating complications, both because of the critical area of this cervicomedullary junction and the presence of the vertebral arteries. So to delve into surgery in this area, you have to be very careful and you have to be sure of what you're doing. When I began, or most of us begin, it starts with, that I know everything. And then suddenly you start getting your complications and you start getting upset and realizing that it is not so easy. This is the Dunning-Kruger concept of learning anything that is complex. As your knowledge in the field increases, then it starts making sense, and then you start realizing that it is complicated, but it can be done if you go through the proper technique of learning the anatomy, the surgery, and applying those things properly. Too much of confidence or too much of diffidence is not going to get you anywhere. Necessity is the mother of invention. Research, the word research means first means look back, search again. The answers are there behind us. No knowledge is original. Everything is written, rewritten to be thrown in the dustbin, only for new work to emerge out from that dustbin. This is where I've done most of my work, and I work now predominantly at Pune Hospital. I have no disclosures except gratitude to my mentor, Professor Ramani, and my dear wife, who's been my immediate junior, my anesthetist for so many years, and my partner in my life for so many years. No other disclosures. So the story begins of atlantoaxial fixation. When I began in neurosurgery way back in 1980s, that time it was about doing posterior spinous wiring, Alexander's technique, and the technique of passing sublaminar wires or keeping the pair, putting bone graft, onlay bone graft. Still the work of Nagel came in and this was the work which kind of revolutionized the technique of how to fix the atlantoaxial joints by passing a screw across the joint. And believe you me, to date, the Nagel's technique remains the technique with 100% fusion rate. The only problem was that the vertebral artery and its anatomy prevented the performing the technique in almost 30% of the cases. You see, the stiffest stabilization with least amount of rotation and lateral bending occurs when you do a transarticular screw. But this was the problem. The vertebral artery can be high riding in 30% of the cases, and then you cannot do the Nagel's technique. And then, of course, my friend Atul Goel in 1994 and Harms much later in 2001 described the technique of posterior atlantoaxial fixation using screw plates and then using polyaxial screws and rods. However, for long, Atul's work was not given recognition, and people kept on calling it Harms technique. And we had to really struggle. And even I myself, I've been quoted in this article where I have repeatedly at many meetings impressed, and now people have started calling it as Goel-Harms technique. However, if you study the anatomy of the vertebral artery, even in the Goel-Harms technique, there's a potential for injury to the vertebral artery. There's a potential because in spite of all precautions, the par screw and the pedicle screw both can be in your way in certain number of cases. And in spite of the best precautions, you will see now neurosurgery in the CV jumps, they talk about using preoperative bone models and 3D printing and using navigation. All this is because there's always a chance of vertebral artery injury, and vertebral artery injury can be devastating. But when you look at the CT scan, unfortunately, the CT scans which are done, they are done in the axial planes, and they miss on this aspect that there's a lot of dense bone available under the facet, which is always available for fixation and which can give you rigid fixation. I will show you how. So if you pass the screw just under the facet joint, your screw passes anterior to the vertebral artery. So there is no discussion left about the vertebral artery. You pass the screw and into the true pedicle. If you pass the screw like this under the facet straight into the body of the C2, and the discussion of vertebral artery injury is over. Because the weight transmission is predominantly along the facets, the most dense bone lies under the facet. So you are holding onto the most dense bone by passing the screw under the facet. So these are some examples. You can see this. Though the vertebral artery can be high riding, still if you do the coronal scans properly, you'll find at the beginning there's a lot of bone available in the facet. This cut in a coronal sense is much behind as compared to this cut. So this is an example. You can see this atlantoaxial dislocation, and you can see this, and you can see the screw. The screw has not gone through the part of the pedicle, but has gone under the facet. And these screws are divergent screws, unlike the screws in Goel's technique or Harms technique, which are sometimes convergent, and that is bad physics for fixation. Now you can see this is an example where you can pass the C2 screw cross screws. This was described by me in 2016, that even it is immaterial when you're using a polyaxial system where your screw heads lie, whether they lie one above the other or they lie one beside the other, or they lie crossing each other. It is unimportant as long as the knee is tightened. So you can see this, the vertebral artery, and you can see the screw passing just under the facet. And this was described as called as a new entry point for C2 fixation in Goel-Harm's technique. Reducing this, the reviewer of this article was not ready, and he was a very senior. I will not reveal his name. Very senior spinal surgeon. He was happy with the technique, but was refusing to accept the word, negating the chance of vertebral artery injury. So I had to correct it and put it as reducing the chances of vertebral artery injury. Then it got published at various places. But then I was not happy with neither the polyaxial system nor the plate which has been described by Goel, which is just a screw plate. So I devised this VSP screw plate construct. This is borrowed from the concept of Arthur Steffi in the lumbar spine. And you can see that this was published in 2019. I had shown it at the AANS meeting, which consists of a VSP plate where you had a variable position where you could fix the screw. And by doing this, you can effectively kind of reduce the atlantoaxial dislocation by manipulating the screw heads and get the reduced position by manipulating the screws. And special instruments were made for me by John. And this technique, of course, got published in 2020 in the Journal of Neurosurgery, posterior atlantoaxial fusion with new subfacetal axis trajectory, avoiding the vertebral artery, and with a customized variable screw placement and screws to enhance the biomechanics of fusion. This video is available on the internet, and it came up as a cover page article on the Neurosurgical Focus video. So I feel that it is a very simple technique. It involves using this Steffi kind of screws which are passed into the lateral mass and into the axis. And then because these can be manipulated, you can make use of the VSP plate, reposition the way you want the atlas over the axis, tighten the nut, and then you can break off the excess rod, excess screw heads. So these are, again, there are specialized instruments for this, making the technique simpler. And if you see, the divergent screw is always superior to parallel screws or convergent screws. In the technique described by me, the screws are divergent, and this is the divergent screws is biomechanically much stronger and much superior. So these are some examples you can see where it has been done, and this is another example. And very recently, in November 2022, the application of this was an article which came up where they have worked on this, and they have found how effective it is in preventing vertebral artery injury in the treatment of complex CVJ anomalies. And they feel that this technique requires more investigation, which was described by me way back in 2016. And then, of course, again, recently, article by Professor Deepak Singh, where he describes the various techniques of C2 screw fixation in atlantoaxial instability. Even he draws attention to the simplicity of this technique in complex cases where the anatomy of the vertebral artery can be treacherous. And he has outlined the numerous strategies for C2 fixation in atlantoaxial instability, in which he describes this technique as a very useful technique. Now, having gone through that, in spite of all this, you will find that, if you see the lumbar spine also, the entire surgery is moving anteriorly. If you see all recent literature in lumbar spine, people have realized that the fixation and fusion has to be done along the line of weight transmission. And ALIF is now taking over. Similarly, you'll find that the cantilever construct is inferior to doing a construct from the front directly. See, conventionally, we have been doing surgery from behind because neurosurgeons were not general surgeons, not trained in anterior surgery. Anterior surgery of the spine came in much later after posterior surgery. But if you study the weight transmission, a very small amount of weight gets transmitted behind in the atlantoaxial joint. Most of the weight is transmitted via the condyles, via through the lateral mass, from the lateral mass to the facet, and from the facet onto the body. And if you notice that most of the dense bone lies over here, and this was a beautiful article by Men and VK, who have studied the relevant anatomy of the axis and the stress lines. Trying to fix from behind is trying to ride the horse like this. So if the weight transmission predominantly from the front, then a technique which does the fixation from the front, avoids the vertebral artery, the venous plexus, etc., and of course is safer. Probably because we were not using microscope in the beginning, most of the cervical spinal surgery was done, with bare eyes. So people focused on fusion and fixation from behind. We went up to C3-4 disc, but did not venture higher because there was no vision and no light going in. But if you see that the mandible is going above the C2-3 discs, which is in 95% of the cases, there is no need to do posterior surgery. And this position is the position of reduction of the atlantoaxial joint. So if you look at this X-ray in extension, and if the mandible angles are going above the C2-3 disc, I think doing the surgery from behind or from the mouth transorally, I think is a wrong option. When you do the surgery from the front, in most of the cases, you just have to disconnect only a few fibers of the longus colli. The rest of the route to this is between the muscle planes. Just by taking the sternocleidomastoid behind the omoid, you may or may not, there's no need to divide when you do high cervical spinal surgery. Whereas when you do surgery from behind, you have to detach all these muscles and destroy the posterior tension band. So embryologically, we have to remember that the muscles develop before the bones. In congenital cases, I feel if you see and go back, most of the cases of congenital CVJ, you will find that the C2 spinous process is big and enlarged because the muscles are trying to hold the occiput onto the C2. To disrupt and destroy the tension band is bad biomechanics. And if you will see what keeps the bone in the dislocated position is the longus colla and the rectus capitis anterior. And without dividing these muscles, you are not going to correct the deformity. To create deformity, you have to first create instability. This is a basic principle of deformity surgery. And what is keeping the position deformity is the longus colla and the rectus capitis anterior. And if you will review the scans of congenital deformity, you will find on MRI these muscles are hypertrophied and thickened. And detaching them is a secret to get a correction of the deformity. So whenever you're considering fixation, you have to find out where is the force nucleus, what is the line of weight transmission, what is the quality of bone available, and whether the technique is safe and simple. I get very disturbed when people say that, this is a very CVJ fixation, a very complex technique, and that you have to be very careful. Then the operation has not evolved or the surgeon has not yet evolved. So if you'll see when you reach over here, there is no structure. The vertebral arteries have gone away laterally. You have got a big block of bone. There is no C2 root. There is no venous plexus. There's a large bone available for you to pass the screw across the joint. And mind you, when you pass the screw across the joint, that technique is superior to every other technique. And the technique, the screw should go posteriorly towards the posterior edge of the lateral mass. And these are all landmarks which are very easily visible on the C-arm image. You do not require navigation. You do not require O-arm. You do not require a robot to do this surgery. So if you see that in 2005, Sen MK described that the anterior surgery is superior to the Megal's technique because you can put a lot of bone grafts into the joint. Then, of course, over a period of time, now you can see in 2020, there's a lot of resurgence and people are looking back into this technique that ATCF, anterior C1, C2 surgery is a valuable option. Over a period of time, you see, that since 2010, then Dr. Y.R. Yadav in 2017 also has described this technique. Then this article, and then recently in the Journal of Spinal Surgery from India, 2022, Vinu Gopal, who's a good friend of mine, he has published his experience. So there is a lot of resurgence. And what does he write? That the technique of anterior retrophageal surgery described, popularized by Patkar, he says that it is a good option compared to the gold standard of posterior approach to atlantoaxial fixation in terms of patient outcome. This is the editorial which got published just last year. So there is a lot of bone available for fixation. The technique is very simple. Under the C-arm, you can use the, you can see the trajectory of the drills. It is very simple. You do not require a lot of instruments, just a few right angle retractors and maybe a good drill system and a few screws. There is no need of any complex instrumentation set. I get sometimes surprised to see these big instrumentation sets provided by the companies where there are so many unnecessary instruments, and probably they have even instruments to open the box and instruments to close the box. So these are some examples. You can see this AED fixed with the anterior trans. Simple screws, hardly they cost a few ₹100, in terms maybe a few dollars. And you can put adequate amount of bone graft in the joint. When the important part of atlantoaxial fixation is the gardening of the joint and putting bone graft into the joints. And that after preparing the end plates, which can be done without any fear when you operate from the front, vis-a-vis when you operate from behind with the vertebral artery on one side and the spinal cord on one side, it is not an easy game. So this is another example. You can see how this is done. This simple two simple screws to treat atlantoaxial instability. Then you can make use of plates also to fix it, and you can put large. Initially, I used to use large tricortical bone grafts. You could reduce the basilar invagination by putting the tricortical bone grafts inside. And I usually like to have bicortical purchase because that is a very strong purchase. You can see these examples over a period of time, how the joint has got fused. That should be the end point of the operation. This is another patient of orthodontoidum fixed with, and you can see inflection, extension, the anterior trans artery. There's no need of doing occipitocervical fixations. And all this through a small incision under the mandible, in the muscle planes, without disrupting the posterior tension band. Very, very simple technique. And you can see that the neck movements remain unrestricted because the posterior tension band and all the muscles still remain preserved. Remember, muscles, when they are separated from the bone, they always heal with scar formation. But look at this patient. Also, the posterior implants, the polyaxial screw rods, they prevent the muscles to fall back onto the bone. This is just to show that there is no hypoglossal injury, and this is the after about a year, there must be solid fusion of the joint. The implant is a redundant thing, which is there only till the fusion takes place. I tell students, never get impressed by the implants and the instruments used to put the implants. Focus on the fusion. The fusion is the operation and not the fixation. So this is a case of TB spine, which would have probably ended up in occipitocervical fixation, which is treated like this. And just to make things a little in the perspective, The supine position is it essentially reduces the deformity, and that is what is the most important aspect of this operation. Just a second, let me come. Yeah. So this is the patient is in the supine position with the head extended. The incision is taken just a few 2.5 centimeters below the angle of the mandible to protect the marginal mandibular nerve. And once you take this incision, so you will see I will show this technique, very simple between the planes. The next important structure is the hypoglossal nerve. And once you do that, you are straight onto the cervical spine and onto the joints. So this is the skin, then you divide the platysma. After dividing the platysma, you will see the submandibular gland and the digastric muscle. Once you identify the digastric muscle, you have to reach up to the anterior end where it gets attached to the hyoid bone. This is the styloglossus muscle which needs to be divided, styloid, and you can see the submandibular gland above and the digastric tendon all throughout its length. This is just an anterior cervical exposure. You got the stylohyoid, which is divided. And once you identify the hypoglossal nerve, with blunt dissection, like you do for a cervical spinal exposure, just anterior to the carotid arteries, you do blood dissection, and you will be straight onto the body of the C2 and the atlantoaxial joints if the X-ray showed that the angle of the mandible was going above the C2-3 disc. So these are the retractors which are put, and you're bang onto the atlantoaxial joints on both the sides. So this is midline, and these are the atlantoaxial joints on either side. You've got various ways to treat them. The first thing you need to do is open the joints, curating them and putting bone grafts. This is the first and most important part. And then you can put screws across, make screw holes and put a plate across, or you can pass anterior transarticular screws. Now this is in live surgery. You can see after exposing, this is the midline, this is the longus colli muscle. And the joints are just lateral to the midline, and with a sheathed cautery, you see the cautery has to be sheathed so that it does not cause damage to the surrounding structures. This is like the anterior cervical spine exposure. You cut the medial portion of the longus colli muscle, and you will very easily open up the joints. There are on both sides, you can see the joint will be very easily seen. You can see this would be the lateral mass of the atlas, and I'm cutting the ligament, and you can see the undersurface, the atlas. Now, this gives you an excellent opportunity to prepare the joint. This is the most important part of the operation. And this is the facet of the C2, which you have exposed and will go onto the body. You can put the drill inside, and you can prepare the joint surface very comfortably, which you cannot in posterior surgery. You can see I'm preparing the joints on both sides. And once they are done that, you can harvest a corticocalculus graft through a small incision from the anterior iliac crest. And you can see this is I think the surgeon must focus on this part of the operation, that there should be bleeding from the end plates. And if you're not getting that bleeding, then your operation technique is faulty, and your implant is going to fail over time. So once this is done and you get bleeding bone on both sides, you can see how the joint has got opened up. I'm packing the joint with bone graft now. Once this is done, then I've got options of either putting a transarticular screw or putting a plate across the joint, which I'll show you. So these are examples. Of course, you can get complications like this where the screw does not go in the correct trajectory. Sometimes, you're overconfident, and in this case, the screw I not drilled properly, and the screw distracted the joint, and the patient woke up with the torticollis, which had to be corrected. These are some implant failures, mal-directed screws. So any operation has complications. If somebody says that he's not having complications, he's either lying or has not operated enough. But of course, with increasing amount of experience and number of cases, the chances that this happens is less. And you have to sit down with every complication and ask yourself what you could have done to avoid it. And I will show you further in this. See, this was a patient where I had fixed without holding the head in extension. And I had to redo this case. And this is a case where one of the screws had come out because I did not have a long drill bit. So I had to remove them and put a salvage screw, which was wider. From the front, when you do surgery, you can use screws even up to 4.5 mm. So you must have a lot of options available to treat them. In this is where I had a transient hypoglossal weakness and marginal mandibular weakness. But fortunately, this did not last more than 2 to 3 weeks. So there are complications. You cannot hide from them. I had published them way back. This was the first time when I published in 2013 the anterior extrapharyngeal approach, how to do it, and the various problems in the technique. And this was the first time in English literature where I described unilateral approach with bilateral screw plate fixation and using bone grafting of the C1, C2 joints. Nobody had described this before, using plates to fix the C1 atlas and axis on both sides from a unilateral approach. People had described some techniques of doing fusion by putting bone grafts, but nobody had used plates to fix them. Then, of course, these were the various techniques. Then the next thing that caught my attention was odontoid fractures. We all know that type 2 odontoid fractures need surgery for various reasons. And the most important one is that the reason cited is that the distal fragment goes into avascular necrosis and the patient can get devastating instability. But we also have to note that odontoid fractures are not alone. They can be associated with a lot of ligamentous injuries and various other fractures like Jefferson's fracture and Hangman's fracture. So in every odontoid fracture, you must study the fracture and the surrounding bones in detail, and you'll find that pure odontoid fractures occur only in elderly in the Western world, and most of the fractures that we treat here, high-speed accidents, they are complex odontoid fractures. There is no consensus about what is the correct treatment of odontoid fractures. This anterior odontoid screw is a very famous technique cited by everybody, but I think it is not a very, very biomechanically very standard technique. I'll tell you why. So there is no randomized control trial since it has come in. Everybody's talking about anterior odontoid screws, and you'll see that most of the literature is focused on geriatric population, which is a simple odontoid fracture, not associated with ligamentous injuries and other fractures. But odontoid, mind you, is a non-weight bearing bone and undergoes a lot of changes over time. And passing an odontoid screw through the odontoid is a very, very simplistic approach to treat odontoid fractures, and has got a complication rate and non-union rate approaching more than 20% if you see the recent literature. When there's a non-weight bearing bone, the treatment of choice has to be a plate. For example, a humerus fracture is never treated by passing a screw. It is always treated by passing with a plate, whereas the femur can be treated by a screw, tibia can be treated by a screw because they are weight-bearing bones. Odontoid is non-weight-bearing bone. Doing C1, C2 fixation from behind for odontoid fracture is actually using a technique of external fixation, not direct compression at the site of the fracture. So potentially unstable fractures are when the LR ligament has been disrupted, when there is no facetal alignment. This combination of the fracture, there's displaced fragment, the fracture involves the superior facet, and there's associated fractures. These cannot be treated by anterior odontoid screw and invariably always end up in doing posterior C1, C2 surgery. When you do odontoid screw, there are too many requirements. Your screw has to be perpendicular to the odontoid fracture. If not, this is what will happen. Secondly, the screw must always go beyond the distal cortex. And most of the people, they make the mistake of passing the screw either very close or do not go beyond the distant cortex, and then the screw can fail. So this is an example where the screw has not gone beyond the distal cortex. The screw is very close to the anterior cortex, and this is what happens. This is doomed for failure. So I came out with this technique where we use a VSP plate again from the front, and one screw is passed into the distal fragment and one in the proximal one, and then we cause compression at the fracture site, which is the basic way to treat this fracture. The basic principle of orthopedics is that you have to have compression at the fracture. So these are examples where there's a displaced fracture, you can reduce it, realign it, and then fix it with a plate screw. And the end point must be that the odontite has been reformed, the posterior cortex has been reformed. This is the technique which is the correct technique to treat a non-weight bearing fracture. So you can see these are examples and another example, and this is how, and if there is associated instability, you can pass bilateral anterior transarticular screws with grafting on the joints of the same sitting. And this was the construct, that is a VSP plate to cause fixation of fracture in compression mode with bilateral transarticular screws. And then you can see classic odontoid fractures we don't read textbooks as a vertical fracture with a hangman's fracture, not reducing with traction, and there's a hangman's fracture also. This patient is treated with a plate screw, anterior transarticular screw, and all done from the front without including the occiput in the fixation. This kind of fracture would have ended up in occiput C1, C2, C3 fixation. This was treated by the simple technique from the front through again a small incision under the submandibular region and preserving the neck movement. At the end of 6 months, you get solid fusion across the odontoid. The odontoid has fused, the C2-3 disc has fused, and his neck movements are free. So this technique remains superior to all other techniques of doing odontoid fixation and got published way back in 2017. Anterior retropharyngeal plate screw fixation, bilateral anterior transarticular screws for odontoid fracture, a new comprehensive technique. That means a technique which can treat any kind of odontoid fracture. Of course, it came up later on in other journals. This should be the end point where the odontoid is reformed and the joint has fused. At 6 months, if you don't get this, that means your operation has fallen short. Now, this is a kind of fracture, which cannot be done by odontoid screw up from behind. It's not reducing, but from the front, you can reduce these fractures very easily by impaling the odontoid, getting it back in position. Over a period of time, it starts fusing. So this is how you do it. You cut the longus cola and you can make a hole in the odontoid, realign it, and then pass anterior transarticular screws. And you can see this. This was how it was impaled, brought into position, and transarticular screws were passed, and it has already started fusing. So this technique again was published recently, the new treatment. Now for anterior inclined fracture, you have to end up doing posterior surgery. But if you use a VSP plate, see the screw is passed close to the edge, and as you tighten it, it will compress the fracture. So there is no need to do posterior C1, C2 surgery for this kind of case. You pass a whole screw and then pass the distal screw close to the edge and tighten it and push it upwards. It will reduce the fracture and cause the fusion in compression mode. This kind of displaced fracture would have ended up in transoral odontoid excision and then posterior surgery, but you can reduce them, get them back into position and fix them by this technique. And then in addition to that, because the joints were disrupted, you pass bilateral anterior transarticular screws. So this was, again, has come up in operative neurosurgery as one of the techniques for doing complex odontoid fractures. And then last year in Journal of Neurosurgery case lesson, unstable odontoid fractures, a technical appraisal of the anterior extrapharyngeal approach for reduction in internal fixation of irreducible, unstable odontoid fractures. And the videos are there in this article. They can be easily seen on the net. Then the next thing that caught my attention was basilar invagination. There is no consensus for treatment, whether to treat or not to treat, if to treat, what is the best approach, etc., etc. And of course, again, Dr. Goel's work about distraction has caught attention. But then it is not easy in all cases, and we have to select the cases properly. Of course, my friend Sarat Chandra from the AIMS has got new thinking, and he talks about a complex way of, that the facets are responsible for the facetal malalignment is the cause for basilar invagination. And his technique of DCR, it is, I would say, one of the, not very easy techniques, but he has got good results with this technique. Congratulations to him. But I feel that there are certain patients, for example, patients where there is a fusion, or patients who have got completely oblique joints, no technique can answer all kinds of problems, and you have to kind of titrate according to what is the problem and decide what technique you want to do. But what you remember that in basilar invagination, the atlas slips anteriorly, the vertebral venous plexus, the vertebral artery, C2 root ganglion, and the posterior tension band. These are very important structures which require attention. Again, like I say, that anterior surgery is very simple. You open the joints and push cages which are wedge-shaped inside, and then put the plates. It is going to push. It's a basic principle of physics that you have got this kind of example, where you push a cage inside, it is going to reduce and push the odontoid down. So these were customized cages made for me by Jeon, which are small and wedge-shaped. So you push them inside, and once you push them inside, they'll realign the atlas, and you can see fusion is taking place across the cage. And this is an example, and you can see how it is reduced by pushing the cage. So the attention from Chamberlain line and Fishgold line has now come to what is known as Grab-Oaks line. That is, you draw a line from the clivus to the posterior end of the C2, and the amount of odontoid behind, that is what decides the cervicomedullary strain. And this acceptable is 9 mm. You have to reduce this, and how you do that, that should be the focus of the operation. So this is a patient with 9.1 mm, and after putting the cage, you can see it has come down to 4.4 mm. So reducing the cervicomedullary strain and fixing the instability, that is the focus of the operation. So when you push a cage inside, the cage, which is, because it is wedge, is the principle of physics, it will push the atlas upwards and backwards, and you've got a big block of bone, both in the lateral mass and in the axis body, to fix it. And you can fix that. It's a very simple technique. In most of the cases, you can see these examples where you can see this odontoid which has gone up and how it has come down. And this is another example. how it is reduced. I put up to 8 mm cages, 9 mm, and bring the odontoid down. Of course, this was first published by me way back, anterior facetal realignment distraction for atlantoaxial subluxation with basilar invagination. And then subsequently, it was invited, I presented my work at APCSS, and they invited the article, and it got published in Neurospine for demystifying surgery for basilar invagination. And then again, in 2020, in Journal of Neurosurgery, the video is there. For those who are interested, they can see the video and the technique. And then I'm now in the process of making this kind of spacer, like the low profile, which can be put in the C1s. I've just done few cases. Still, you have to have a follow-up of more than a year and a half and prove yourself that there is fusion and the implant is holding before you start talking about it. So this is a very simple technique. You can see this. The concept is very simple, that you open the joints and push the cage inside the joints, and the cage will, and then put the plate with one screw in the lateral mass, one in the body, without any fear of any kind of vascular injury. So this is how it is. Once the cage is pushed inside, automatically it is going to drag the odontoid downwards, and then you have got these screws which will treat the basilar invagination. The construct is very simple. And on table also, you can reduce basilar invagination by pulling the odontoid, by impaling the odontoid and pulling it in the front before you do your fixation. This is a very important step which cannot be done from behind. So this is another case where there's basilar invagination and there's only one dominant artery, the other side artery is absent and it is coming dorsally. So this was a nasty case. It cannot be done from behind, according to me. And then I studied anteriorly whenever there was this joint, which the atlas was moving upwards and downwards and anteriorly. So it can be, this is a very difficult cases for passing transarticular screws and even for putting the plate. So when we studied the joints and the angle of the joints, and you see this, how it is inclined, after we put anterior wedge-shaped grafts, the atlas was pushed upwards and backwards, and then screw was passed into the lateral mass of atlas, and a specialized customized plate was used to bring the odontoid down and fix it. And you can see that there is a bicortical screw. So this is a 3-point fixation with distraction and realignment, and the basilar invagination has been reduced. This is the pre-op MRI and this is the post-op. So this was a construct where there's a 3-point fixation with screws going to the lateral mass of the atlas and one screw going into the body of the C2 and going right up to the posterior cortex. And then I worked on to make this plate for all kinds of atlantoaxial fixation, where I see the direction of the screws, the angles, the distance between the midpoint of the joints. They vary from 2.25 mm to in some patients they are up to 40 mm. So an area of plates has been made for me, and I've used them in many cases. This I published is coming up in British Journal of Neurosurgery, and I presented it to the Society of British Neurosurgeons at Blackpool at the last Society of British Neurosurgeons meeting. And you can see this, even complex odontoid fractures which are impacted can be realigned and fixed by passing the screw into the lateral mass. You get a large volume of bone to hold on to and into the body of the C2. And I'll skip this video. So the advantage of doing anterior surgery is that you can prepare the joints by passing the drill right inside. And this was how the technique is. After exposing the joints, you keep the plate, mark the entry points on at the anterior inferior edge of the atlas, and the screw goes directly into the atlas. And once the center, so once I marked this, then I know what is the direction of my screws. I keep the plate, and this is how the screws will pass into the lateral mass and the body. So this is on table. You can see this in the live surgery also. It is a very simple technique. Does not, it can be, I call it an idiot-proof technique, where once you've entered into the lateral mass and know the direction and trajectory of the lateral mass, you're not going to make a mistake, because you've got the C-arm, and the screw goes directly into the lateral mass and one screw goes into the body. I don't like to over tap, just 1 or 2 threads to get into the for the screw to get in, and tapping just makes the trajectory very loose. And you can see this. You can go up to a size of 30 mm screw length in the Atlas, and about 25 mm to 30 mm in the body, in the Axis body. And once you have got the direction with the tap, you don't have to struggle much. And the lateral mass is very rock solid bone. Once you get a hold onto the lateral mass, you'll fix the joint. Once you, and at the C2 you can put a 4.5 mm screw, which you cannot do in posterior surgery. So this is a 4.5 mm screw, and you can see how this has got fixed. And you'll see that on table itself, you will be able to see that if the joint has got rigidly fixed, it is not going to move. This is a 3-point fixation, mind you. When you do surgery from behind, there are implant on one side and implant on the other side. This kind of fixation is superior to that. So this, of course, got published, basilar invagination in JOCR. It's there on the PubMed for that, with a follow-up of more than a year to show how this implant holds on. And these are some examples of osteodontoidum. And you will find that a 3-point fixation way back in 2000, it is superior technique for fixation. So these are examples. You can see this odontoid, and you can see this another example. So vis-a-vis 2 fixations, a single fixation fixing is superior 3-point fixation. And this is the new plate made by Jeon for me, where you can even lock the screws. So it's a locking plate now. This is what I'm using. This is the last few cases have been done using this plate. And I feel that this kind of implant is, is out of the window. So if the problem is anterior, you have to treat it from the front, reduce it, fix it from the front, and you can treat most of the cases. Now, this is another aspect which caught my attention was the posterior surgery, the curse of Zeus to carry the weight of the. I feel carrying the weight like this is, much more easier and simpler. So this was a case where a patient came with incomplete excision of the odontoid with infection behind. So there's nothing to hold on to the C1, C2. So necessity is the mother of invention. This was the implant which I described, where you fix the occiput skull onto the anterior bodies of the C3, 4. And this is a long-term follow-up, flexion extension with the implant holding, where you can transmit the weight of the skull onto the bodies of the cervical spine, because you can see even posteriorly there was nothing available. So this is a different technique. This is a case of fibrous dysplasia. There was nothing to hold on to. Somebody had biopsied it, and then the patient had developed a pathological dislocation. There's almost no bone, and this is how the fixation was done. And this is now more than 2 years now, because this I had presented at AANS meeting more than a year ago, to 3 years now. And now the bone has reformed with medication. So this is a simple technique which I feel is not very, very complex. You give little thinking to it. You can see you expose the vertebral bodies and go lateral to it. There's no structure of importance lateral to the transverse process. There's a safe area over here. So these rods, they're customized, again made by John, bent at 2 places and pushed through the muscles. Another one pushed through the muscles, and then there were specialized connectors which fix onto the bodies without encroaching onto the esophagus. And once this is done, you can see this kind of fixator which holds on to the rods. The rods will project lateral to the transverse processes posteriorly. The patient is then turned prone, and you can see these rods coming up. And you can make small vertical incisions where the bone is thickest, and you got the specialized plates to fix it. And then the rod can be passed through this with a domino connector. And then once the rod is passed, it will come and hold on through the domino connector to this rod. And this is how you can reposition the head and fix it, tighten it in that position. This is how the implant looks finally, but it works. I've done the cases and I've published my work, and this is how it works. See, this is a case. And once it is reduced and brought in, there was almost no bone available for fixation in between. And over a period of time, this patient was in bed for almost 6 months, and she's very happy and says how she got up after 2 weeks and she catheter went away, etc., etc. So craniovertebral fixation, a new technique. This was published, shown at ANS, and then subsequently published in Neurological Research and in JOS. So I say that always keep on thinking, is there a better way? Is there a better way? To be happy is to be done. And of course, I've been presenting my work at various national institutes and in different countries around. And I feel that the truth is more important than the facts. The facts are what you see. The truth is what exists. If this guy could get a beautiful woman like Katrina Kaif, then everything is possible in life. Thank you, my dear friends. Hello.
Hello.
I've
Yes.
finished. Thank you very much.
Asheesh, please.
Yeah, excellent.
Hi, sir. Yes, sir. I think Yadav sir can moderate the session.
Okay, so I think excellent lecture. As always, Dr. Patkar gives something.
Thank you.
And excellent talk. So obviously, I think the basic problem in AD lies in the joint. So people were doing it from back in the beginning and saying that the most of these dislocations can be reduced. So there is nothing like, irreducible AD, and it is true also in most cases. But there are cases which Dr. Patkar has already enumerated, that there are problems where in about 10 to 20% of these patients, reduction is either not complete or it is not there at all. If there is a callus formation, if there is something in anti-arch of the atlas and odontoid, in such cases, it is impossible. So the added advantage of Dr. Patkar's procedure is that, if you are not able to reduce it, then you can decompress it from anterior side. And obviously, the fact he's telling that approaching it from anterior is far better than when you go from posterior side. So it can be done from posterior side. It can also be done from anterior side. The advantage of anterior approaches are that there is a bicortical screw purchase. You see, you have to understand that even if you go little more beyond the posterior margin in the lateral mass, nothing happens, especially at C1, or I do C1, C2 lateral mass. So even if you go beyond, posteriorly beyond the cortex, nothing happens. But if you come from anterior side or posterior side, then you are always worried about dysphagia and other things. So this is one advantage. Another is that there is a avascular plane, which he has explained. Then the tension band is very important. We all know that for cervical alignment, the attachment of the C2 spinous process, lot of muscles are there. So these are important muscles. One should try and avoid removing these things, which has to be done when you go from posterior approach. So this is another advantage. The other thing is that the position. You see, when you go from posterior approach, then you have a prone position, which is difficult. And at times, even during the positioning, you can have injury to the cord, especially if it is a so-called mobile AD. But in anterior approach, position is supine, so this is far better. And I've already said that in case there is no reduction, then you can do a decompression. I do it endoscopically. So if always I try to reduce first, but if there is no reduction, then I take out the odontoid process and remove even up to the C2 vertebral body. And in such case, I put in screws in the lateral mass of C2. So you can put in, if the C2 is not available, you can put the screws in C3 also, or you put the screws in the lateral mass of C1 and C2. So excellent work done. And there are less chances of vertebral artery injury also. This has already been very nicely explained by Dr. Patkar. So congratulations, Dr. Patkar. Excellent work. Any other comments or any questions? I think, sir, Professor John, is there any?
So there's one question from Dr. Harshad Parekh, and he has asked, when do you decide to do a posterior fixation? That's a question.
Should I take that question?
Yeah, it's for you, sir.
Yeah. So if you cannot get the angle of the mandible going above the C2-3 disc when you are in extension, because the preoperative evaluation shows that you cannot extend the head, and sometimes people have short neck, or there's people with degenerative spine, they're unable to extend the head, then of course the posterior surgery is the surgery of choice as compared to anterior surgery. Apart from that, I do not find any reason why you should not be able. I would feel that eventually, just like cervical spinal surgery in the subaxial spine, when I began in neurosurgery, most of the surgery was from behind. Today, 90% of cervical spinal surgery is from the front. Similarly, in atlantoaxial instability, if the reduction is possible in extension, then most of the patients would end up in anterior surgery, and there will be only those patients where you cannot extend the neck, then you have to, and the angle of mandible is not going above the C2-3 disc, then you should do posterior surgery. The second question is, where do I get the graft? I take a small incision from the right iliac crest, less than a centimeter, and make use of a specialized kind of trephine, which is used to harvest corticocancellous bone from the right anterior iliac crest if I want to put a lot of corticocancellous bone into the joints. And you can get a lot of bone through a small incision in the iliac crest.
Patkar sir, I got one question.
Yes.
Can you hear me?
Yes, I can.
Sir, in the early part of your presentation, you said once that to correct a deformity, you need to first create instability.
Correct.
Like what you always say. And did you mean with that, like in congenital CVJ anomalies, as you rightly said, there are a lot of hypertrophied musculature behind developed as the anomalous part. So do you mean that in some congenital CVJ anomalies, it is preferable to do that posterior tension band release first?
No. What I meant to say, can you hear me?
Yes.
What I meant to say was that in congenital anomaly, the anterior muscles are hypertrophied because the muscles form before the bones. It is these anterior muscles which are formed before, and we are, even in the fetus, see, our head is in flexion position. We are in the curled up position. And those muscles, if they're hypertrophied, they tend to cause the dislocation, and those muscles maintain that atlantoaxial dislocation. So if you see scoliosis surgery, what is previously scoliosis surgery was, the first part was the anterior release to release the vertebra from each other, and then the posterior pedicle screws came into it. There are a lot of people who initially did scoliosis surgery only from the front, but anterior transthoracic surgery is not a very easy operation. But when you release the longus scoli muscles, when you cut the anterior longitudinal ligament, you can reduce most of the atlantoaxial dislocations, which are looking and appearing to be irreducible. If there is no bony fusion, like I showed the video where you can pass a tap into the odontoid body of C2 and pull the odontoid towards the anterior arch of the atlas. And in that reduced position, you fix the joint.
I would like to jump in and just present a few comments. See, basically, I would like to first be a devil's advocate. and there are a lot of youngsters here, and I want to inform them that anterior C1, C2 is not a piece of cake. There is a learning curve to it. At times it is a steep learning curve because there are certain issues to it. One is the angle of the mandible is there. Then there are deep structures. There's a lot of depth in. Thirdly, you don't have too much of lateral movement, which you have in the posterior approach. Also, you have other structures like the mandibular gland or the hypoglossal nerve. So it's not that you can just say that posterior approach is a done thing now. Anterior approach has its advantages, and so has the posterior approach. And I think there should be a case-based selection. And I would strongly recommend that each one who's doing a craniovertebral junction surgery should have both anterior as well as posterior approach in their armamentarium. Now, in case if you have a reducible AAD, I tell you, it can take you just 1.5 hours to do a posterior C1, C2 fixation. Also, as far as the amount of bone is concerned, you get the same amount of bone in a posterior fixation as well, because ultimately the screws, either you put it anteriorly, it's also going to the lateral mass. If you are inserting the screw posteriorly, it is also going into the lateral mass. The advantage of the posterior approach is, even if you have vertebral artery anomalies, there are a lot of other ways to insert the screws. Whereas in an anterior approach, you have certain limitations, like you can either put 2 screws or a transarticular screw. Having said that, there are specific indications where you do need to go anteriorly. Like if you have a lot of, if you have a Pott's spine where there is degeneration or where there's malignancy, or when a C1, C2, as both Professor Patkar and Yadav sir said, that there is fusion of the odontoid with the atlas anteriorly, where you cannot achieve a reduction. So in all those cases, definitely you would require anterior approach. So if you ask me, the way to go for me would be posterior, but I've always kept anterior in my armamentarium and it should be used. So there should be a balance sort of with the approach.
Dr. Yadav, you have now started to, you get a case of mobile AAD. Will you do posterior surgery or will you do anterior surgery?
I do it anteriorly, but I also do posterior. So my indication for posterior approaches are when obviously when the C2, C3 disc space, I mean the angle of mandible is below C2, C3 disc space. In that case, obviously transcervical is not possible because your angle of approach is very acute. So this is another indication, one indication for posterior approach. The another indication for posterior approach is when there is a compression from posterior side. Correct. And you have cases where in ACM, sometimes the tonsil is going very low down up to C2 level. So in that case, I do posterior C1, C2 and also do the foramen magnum decompression. So this is another indication for me for posterior approach. 90% of my surgeries are from anterior approach.
So see, Asheesh, what I want to remind you, this is the same argument which happened when anterior cervical fusion came in for cervical spine. My teachers, they would say that, no, it has to be done. It is more versatile. There's a lot of exposure. You can do good decompression. Till people started doing anterior surgery. Same thing is going to happen with atlantoaxial instability. It's just a matter of time. What Dr. Yadav said, you have to understand, he said most of his cases he's doing from the front. Once you start doing them anteriorly, you will slowly realize the advantages of anterior surgery, and the posterior surgery will be restricted to a few cases.
Yes.
Sir wanted to say something.
The another indication for me for posterior approach is when you have destruction of C1, C2 facet joint. So when the manipulation of the joint is not possible, because there are conditions in tuberculosis and other diseases where C1, C2 facet joints are destroyed, which is very rare. In that case also, you need to go from posterior side. So, but 90% of my cases, even more than 90%, I go from anterior side, but I do it endoscopically. All my cases, initially I did open approach, but now I do it all endoscopic approach.
The other aspect I would like to add is that in syndromic atlantoaxial instability like Down syndrome, you must always use the occiput fixation. Very small children, I feel that especially like Down syndrome and other kind of molecules, you need to include the occiput. And in those cases, of course, you have to do posterior surgery.
Also, sir, as you have correctly said, this, in my group of cases, short neck is a very common element.
Those cases are out. Those cases are out.
Yeah. So, short neck.
90% of the cases, like Yadav said, if you do the X-rays, you'll find that it is possible in more than 90% of the cases.
Yeah.
Yes.
So the trend will change. Like during my time, the cervical spine Bible was the operative posterior spinal surgery by Charles Fager, till Smith, Robinson, and Cloward came onto the scene. And when I first proposed doing anterior cervical spinal surgery at the Nair Hospital, Dr. Vengsarkar almost hit the ceiling. And he said that you will tear the esophagus and rupture the carotid artery. Then I moved on with Dr. Ramani, who had trained with Arthur Steffi and with Cloward, and he said that no cervical spinal surgery should be done from behind. All cervical spinal surgery should be done from the front. Time proved him to be right, and but of course there are still cases where we will still do posterior spinal surgery. So there is no one way to roam. We have to decide the weather, we have to decide what are the obstacles and select our cases properly, but we must pay attention to the trend. Look at degenerative lumbar spine. If you see the Journal of Neurosurgery or spine, you'll find that most of the talk now is about A-lif and O-lif. And it is the degenerative spine surgery is moving from behind to the front. And whatever happens,
so I would beg to differ here again. The other trend is also changing. Deformity surgery, it started posterior, went to anterior, and now everything is being done posteriorly.
Where surgery is a completely different issue.
So, what I again want to emphasize here is that, it's, and also I must tell you, sir, there is a huge difference between C3 downwards for anterior and C1, 2 up. The learning curve is different. The space is different. So, I mean, what basically I'm trying to emphasize here is that the students who are listening to your talk must realize that it is not easy, and it would be better to, go back into the cadavers and with the masters to gain, if you're doing anterior C3, 4 downward, that does not mean that you're trained enough to do a C1, 2 anterior. There is a learning curve to it, and I think it should be respected. Otherwise, you and your problems, patient will land up in problems.
There is no question on what you're talking, Asheesh. No surgery can be, learned from talks by other people. The cadaver is the only place where you can learn surgery. You have to go to the cadaver. You have to go to fresh cadaver. For C1, C2 surgery, I will tell the students who are listening that the way to learn C1, C2 surgery is to bribe the people in the forensic department, go and work on fresh cadavers. Because C1, C2 cannot be approached 3 days after the patient is dead. The patient has gone into rigor mortis. You cannot approach the C1, C2 joint in a cadaver. If you want to learn C1, C2 surgery, you have to go to fresh cadavers. They are available in most of the morgues, but you have to also understand that, like I said, that subaxial, most of us, we have even people who are doing standard cervical spinal surgery, C2-3 discectomy is the common treatment for hangman's fracture. The atlantoaxial joint is exactly 15 millimeters above the C2-3 disc. So this restriction came because people were not using the microscope. Most of the people who popularized cervical spinal surgery were non-microsurgeons during my era and orthopedic surgeons. And therefore, they kept themselves restricted to the lower cervical spine. With the microscope, now Dr. Yadav has brought in a completely new dimension where he puts the endoscope and exposes it. Everything has a learning curve. Everything needs to be learned. Everything requires to be practiced. Nobody can start operating by listening to lectures and looking at other people's work. Yes, I agree with you that everything, but biomechanically, when you look at the vertebral artery, when you look at the venous plexus, this seems to be a more acceptable option.
Yeah, and we are extremely, in fact, we appreciate your effort, not just in India, but around the world for propagating the anterior approach. And we understand the amount of effort you have taken to, establish this procedure. In fact, I very fondly remembered how you have come to our center and operated more than 3 cases through the anterior approach. So definitely, we appreciate your effort in propagating this approach.
Thank you.
So if you, Yadav sir, it's already been 1 hour 45 minutes. So is it possible for you to join us again, maybe 2-3 weeks later, and we conduct with you as a speaker this time and Patkar sir and Nitin again as moderators, and I'll jump in with my small lecture.
Yes, it's possible.
That would
No
be great.
problem. I mean, it is my pleasure.
Okay, so great, sir. So I think if there are no more questions or comments, if there are, please, you can jump in, anybody. If not, then I think I'll thank, starting from Nitin for accepting the invitation and helping us moderate this session. Yadav sir, his presence is always welcome, and his inputs add to the whole learning experience. And again, what can I say for Patkar sir, with his volume of experience and work, we are extremely thankful to him for joining and giving such an elaborate lecture. And mind you, he's in midst of a conference, and he came, he's in a Dandy conference, and he's joined us from there. So we again appreciate. So once again, thank you, John, and thank you all for joining this forum. Thank you.
Thanks, everybody.
Thank you, John. Thank you,
Thanks,
Nitin.
everybody.
Thank you, Yadav sir.
Thank you, everyone. Thank you, Patkar
Thank
sir,
you, everyone.
Professor John.
Okay.
Asheesh.
Thank you.
Okay, Dr. Yadav, Asheesh will send you a proposal, okay?
Sir.
About doing that conference on minimally invasive, okay?
Sir. Yeah.
We'll design a program.
Yeah.
Okay. Thank
Very
you
good.
once again.
Very good, Asheesh. Thank you, Nitin. Thank you, Harshan is always there. He's always backing us.
Yes, John, I'm here, always there.
Yeah, we're off.